Recording. All right. Good evening, everyone. Thank you for joining us. Welcome to this virtual town hall, where we're going to feature some medical professionals to talk about COVID-19 as it affects Guilford. Looks like we have about 84 participants. Thank you for joining us. It is National Doctors Day. I realized that earlier today. So, and actually, just from my own perspective, I want to share with the community that we're really appreciative and grateful to the community for their efforts in limiting spread. It certainly can impact individuals, but the potential for this pandemic to overwhelm the healthcare system is very real. So I want to just express my gratitude to everyone for doing that. Just a little bit about myself. I'm an emergency physician. I've lived in Guilford almost 20 years. I have 4 teenage kids. I work as an emergency physician, but I'm actually on sabbatical with Yale right now, so I just want to give you full disclosure that I'm not working clinically over the last couple of weeks. I am in the reserve pool, and I actually do expect to get called in if things get more overwhelming or people fall ill. So I'm keeping a close eye on things, but I really wanted to actually hear from our panelists, who are a lot of them on the front lines. Very briefly, I'll have them introduce themselves. But we have Karen Goldberg, who's a local pediatrician and also advisor to the Madison school system. Susan Kashaf, who's an internist with the Veterans Administration. Vahid Mohsenian, who's a critical care physician at Yale. Harry Moskowitz, who is an emergency physician and director of the emergency department at the Shoreline Medical Center. Sunil Parikh, who's an infectious disease specialist and also involved in the School of Public Health. Chris Rooser, who's the chief of primary care at the Veterans Administration, and also has been responsible or involved in the VA response, and Marietta Vasquez, who's a pediatrician and infectious disease specialist. So as far as how this is going to run, we'd like to have just a few introductory statements. I'll ask Matt Hoey to introduce this, and then we'll go in alphabetical order by our panelists. We'll ask them to give a 2 or 3 minute summary of where they're coming from and some of the messages that they may have. And then we'll go through questions for the panel in general. Just a few housekeeping things. Please look at the chat and feel free to use that liberally. I will be checking that for the questions. I guess I should just say also, this is a group of local physicians. We have our own opinions and perspectives. This situation is constantly changing. We don't purport to represent Yale or the town of Guilford, even though we may be involved with them. But we're doing our best to just open the lines of communication here. And I think that's where I'm coming from. So with that, let me just turn it over to Matt Hoey for a minute or two.
Chris, thank you very much, and good evening, everyone. I'd like to start off by thanking both Barry Felsen and Chris Moore, who approached me last week about this concept and this idea. I was thrilled when they came to me with that and indicated I was fully supportive. So thank you for bringing this to the community and also bringing this panel of experts that you have arranged for this evening. I am encouraged by the community response, as you have just mentioned, Chris. I think I'm seeing the evidence that people are taking this seriously. They are practicing appropriate social distancing and practices. I'm also encouraged by a surge in some volunteerism that has taken place to help folks who probably shouldn't be out. There is a program going on called Guilford Cares, which is doing shopping for seniors, grocery shopping, etc. That program actually kicked off today. They're hoping to add pharmacy pickups and prescription pickups as well. One quick thing, government is open for business. We have limited rotating staff. I think there are probably only 6 people or 7 people working in town hall, but we're keeping the vital operations open so people can still conduct business. We've implemented the appropriate social distancing and materials handling. So there may be a delay, a day or two's delay in some of your paperwork being processed, but it will get done. We feel that it is essential for the government to stay open, and we'll do so as long as we can. So, Chris, with that, thank you very much for pulling this together, Barry, and the rest of the panel. And I look forward to hearing what you have to say.
Thank you, Matt. And I'm not sure I did mention, Barry Felsen actually was the citizen who really started this off by contacting me and asking about the possibility of this, and he's fielded all the questions. So thank you, Barry. Appreciate your involvement with this. So we'll go down alphabetically with the panelists. Karen Goldberg, can you start?
Whoop, Karen, you're muted, I believe.
Uh-oh. Unmute. Sorry.
Geez, what I said was so profound too. I don't know if I'm going to be able to repeat it. Sorry about that. So I am a pediatrician. I work at Pro Health Shoreline Pediatrics. We have 2 offices, one in Madison and one in Clinton. And it is a very strange time to be practicing medicine right now. I'm doing things that we never thought we would do. So we are doing most of our visits, like many of you probably know, with your physicians via telemedicine. So we are trying to keep kids out of the office as much as possible. We're trying to do as much as we can over the phone. We are having one of our offices be our healthy office and one of our offices being the sick office. In our healthy office, we're still vaccinating our young kids who we, feel like that is a very important thing to continue to do. We don't want a measles outbreak in 6 months. But we have canceled all our other well visits, and we're doing all of our med checks and, anything that we can do over the phone, we're doing over the phone. We are managing a lot of fevers over the phone and helping, determine when we need to see the patients. And the patients that we are seeing are really the kids that we are trying hard to keep out of the ER. So our goal is to see those kids, be able to stabilize them, be able to do what we can for respiratory issues, for infectious issues, and trying to keep them out of the ER as much as possible. We do send kids to the emergency room if we are concerned about their breathing and think that they may need to get admitted. Or if they're really dehydrated. But short of that, we're doing everything we can to keep kids home. In terms of the testing, we are testing for COVID only under pretty strict criteria at this point because the testing is still pretty limited, despite what you may hear in the news. So we are following the guidelines that have been set for us by the American Academy of Pediatrics and the CDC, which is pretty much only testing people that are going to need to get admitted or testing people with an underlying medical condition. And there are other cases, like if you have a parent that's a healthcare worker that needs to go back to work. But we are seeing kids with fevers. We are seeing lots of children that very well may have COVID and we don't know about it. But luckily, most of these kids do very well. And as I'm sure you guys have heard, children for the most part do fairly well with the COVID. That's not to say that there are not kids that have had to be hospitalized, but that is a rare situation. So the important thing for everyone to realize is that even kids who have mild infection can pass it along. So that's why we are making such a huge push to make sure that kids stay home, teenagers stay home, young adults from college stay home, don't get together with their friends, and really work hard to not pass this infection along to their grandparents and to immunocompromised people.
Thanks so much, Karen. Dr. Kashaf.
Hi, I'm Susan, and I'm an internist at the VA where I take care of some of our sickest and more vulnerable members of the population. And it's been a challenge to try to keep those folks out of the hospital and out of the emergency room. But perhaps a bigger challenge has been to work with my teenagers to convince them that seeing one friend is not okay to do, and going for a walk with one friend might not be a great idea. So basically, I'm spending my days, like most doctors who aren't in the very, very front lines right now, trying to do televisits with folks and keep them out of the hospital, keep them out of the emergency room. And I'm really excited to talk to a larger group about some of the things that I spend my whole day talking to patients about in terms of things that you can do to keep yourself safe in this environment, and things that can make your life better that will still allow you to be safe in terms of enjoying our environment. So one of the things that, we talked about maybe debunking a myth, and one of the things that I feel really strongly about is that we live in a wonderful community that is filled with trails. I think every member of our town could be outside at the same time taking a hike in different places without being within 6 feet of each other. And if we are able to be considerate of social distancing, we can still enjoy life in the outdoors and take care of our mental and physical health while doing that. I think social distancing is so essential to our community's health, but being able to understand what that means and do that appropriately is something that I hope that we can talk about as a group today. For example, I see people being close to each other while using gloves, and that defeats the whole purpose of things. So if you're close to each other and you're not observing social distancing, the gloves aren't going to protect you. And it, as a matter of fact, might give you a false sense of security because you think your hands are protected. If that same hand touches your phone or touches your face, then you've defeated the whole purpose of putting a barrier between your hand and what you're reaching for. I go to the hospital to do the televisits because my internet connection hopefully is working now, but is often not great. And I don't wear gloves in the hospital unless I'm with a patient. I wash my hands a million times a day, and I have a sign outside my office that says 6 feet so that anyone, my close talker colleagues, don't come and, talk to me closer than that. So it's a new way of living. It's a new normal that is not going to end within weeks as we had hoped, but is going to take a lot less time if we keep abiding by the things that I see most people doing. My husband and I, he's right here. We go hiking often, and I just love the wide berth that people take when passing by each other, but still smiling at each other and and acknowledging each other in a friendly way.
Thank you, Susan.
Happy to.
Great. Dr. Mosenian. Let me see if I...
Yes, hi. My name is Vaid Mosenian. I'm a professor of medicine at Yale, associated with a section of pulmonary and critical care medicine. I'm one of the frontliners and been taking care of very sick COVID patients with respiratory failure in the last few weeks. And we're getting a constant flow of patients coming through. Many of them actually turn out to have a non-COVID-19 viruses, such as regular coronas that are like a common cold type rhinovirus and some influenza. Nevertheless, we do have a fair amount that are turning positive, and they may require intensive care. For the time being, we do have adequate ventilators and ICU beds, and we are gearing up to scale up as necessary. But I can't overemphasize that the control for this pandemic is not in the ICU, in the hospital. It's actually in the community and you as public. I mean, this is the only way that we can basically control the pandemic. No drugs are available as prophylactic or preventive measures. There are some drugs that are used in the ICU that are kind of more of an experimental and not proven to be robust. So the only way that we can actually control this is to what you already know about, but you need to practice. Social distancing, confinement with adequate Netflix, books, and your internet access so you don't get bored. As Susan mentioned, get out, but don't get too close to your friends and relatives. Weather is going to be improving, and the days are getting longer, so you can stay out, not getting cabin fever. So I can't overemphasize that the control is in your hands, and it's going to be a long time before we will have an effective antiviral medication. or having a vaccine available for millions of people. So don't count on those for the time being.
Thank you, Vahid. Dr. Moskowitz.
Hi, am I muted?
No, you shouldn't
Can you
be.
hear me?
I
Yep.
can hear you.
Okay. Hi, everyone. I'm Harry Moskowitz. I'm director of the Shoreline Emergency Department on Goose Lane. Things have changed a lot in the ER to prepare for this pandemic. And luckily up here in Connecticut, we've had a lot of time to prepare. We're doing our best to keep patients who are infected, believed to possibly have COVID, away from the regular patients that we're still taking care of. You're going to see a lot of people in full protective equipment with face shields and masks. Everyone's doing their best not to spread infection within the ED. But that said, most of our population in the ED these days are people suspected of having COVID. You know, we're still taking care of heart attacks, strokes, people with other breathing problems, orthopedic cases, but the majority of the cases now are fevers, coughs, shortness of breath. All these are symptoms that could be COVID. So the public has been very smart about using the ED appropriately so far and really should be commended. I think they're consulting with their doctors about when to come in. And we're not seeing a lot of ordinary minor cases that don't belong in the ED. And we're able to take care of all the patients with suspected COVID and their other emergencies very well so far. And we're preparing for more of them. So I think the message I would like to give everyone briefly is come to the ED if you're short of breath, if you feel really weak, if you can't stay hydrated. Don't stay home too long because there are things we can do to support you. But if you're not short of breath and you're not very weak and you just have a cough and you think you might have COVID, then the right thing to do is isolate yourself and consult with your doctor about if you have any questions about coming in or getting tested. And if we adhere to those guidelines and everyone continues to self-isolate, hopefully we still have the emergency capacity to get through this.
Great. Thank you, Harry. Dr. Parikh.
Hi, everybody. My name is Sunil Parikh. I'm an infectious disease physician at Yale. I'm in the adult ID division, but also in the School of Public Health, actually, where my primary appointment is. I've been involved in the COVID response on the clinical side, mostly through hearing on our sometimes daily calls about and email chains about what's going on for clinical management. And then on the public health side, in terms of trying to assist both locally as well as throughout the state on developing the proper policies. For instance, there's a group now getting together to assist long-term care facilities in the state and how to address this situation so that we don't have unfortunate circumstances like happened in King County, Washington. I think I'd like to basically drive home the same two messages that have been echoed over and over again, is that, there's a term that's been used more now in the last few weeks on frontline folks, and I'd really want to expand that to everyone. I'd say all of us are really frontline because, as Vahid said, and Karen and Susan and Harry, the main way that we're going to defeat this pandemic is really adhering with social distancing. Unfortunately, the medications that are being studied right now, again, we are giving some medications at Yale. They're not FDA approved. One of them may have just gotten expanded use. The malaria drug chloroquine may have gotten expanded use today, actually, but these are not well studied through controlled trials, giving us the best evidence. So there are things available that we're trying, but trials are still far from being completed. A lot of promising things, but again, the main way we're going to reduce this is basically reduce the spread from individual to individual. And it's a fine balance because obviously this can lead to increased anxiety, social isolation, people not caring for themselves. So it is a fine balance. So I think the second thing I really want to reiterate is that folks need to continue to take care of themselves. I went on a bike ride today just to get out of the COVID 24/7 mindset, and I was surprised to see on a 20-minute bike ride not a single person in their yard today. And it was not the warmest of weather, but I think again, we can get out there just to stay active a little bit. What I do worry about is, a few months down the road, people not exercising, not maybe having the same diet they did, and actually developing worsening underlying diseases that they already have because of insufficient care. So I think as a community, one of the things we can do for each other is really encourage one another to, whether that's staying active in your home or getting out into your yard or other things, making sure that you're getting your medications on time and not letting that prescription lax for a month. Those are all going to be really important things so we don't have other diseases crop up during this time. I think there was a lot of questions that had come up on relaxing the social distancing, and I know there's been mixed messages in the news. From an epidemiology perspective, I think, again, it's too soon to be talking about that, and I think really as a nation, I would not even say just the hotspots, but as in a nation, we really need to continue the social distancing, and it's going to be a little while. I think we're still on the upward slope in terms of cases. We had just our first case 2 weeks ago or so at Yale New Haven in the hospital, and now we're up, nearly 100 plus. So, we're still on the upward slope, and so I think folks should just get ready that it's going to be a bit longer than we had hoped early on.
Thank you. Thank you. Dr. Rooster.
Yes, this is Chris Rooster. I'm Chief of Primary Care at VA Connecticut, and I'm also part of the section of General Internal Medicine at Yale. My experience so far with this has been both at the clinical level and at the systems level. At the clinical level, I was responsible for being part of the team that stood up the VA's drive-up testing center. And I spent most of my day yesterday actually calling back patients who tested positive in the outpatient setting. And in that experience, I think I started to understand what it was like to talk to patients who were at home with other family members and taking the idea of social isolation in a more general way.
He doesn't like you.
How you apply that in the home, in the family setting, and trying to isolate. Maybe when there's a house that just has one bathroom and those sorts of things. At the systems level, I would echo what Karen Goldberg had said earlier. So the VA has been one of the national leaders in clinical video medicine. We already had a system set up whereby geographic disparities in healthcare were addressed by leveraging video medicine to take care of patients who might not have access to healthcare. So for example, we might have panels of veterans who live in Alaska whose doctor is based in Florida. And so some of the crisis that you see happening in New York, the VA's response to leverage virtual doctors all over the country to help deliver care, both for civilians and for veterans, actually. And what's been amazing to me is I looked at our statistics today at VA, and the week ending March the 7th, just 2 weeks ago, we had about 2,700 face-to-face visits or in-person visits in our clinic, with about 500 virtual visits. As of the end of last week, we had 66 in-person visits in all of our clinics, and we had 2,800 virtual visits, both video and phone. So a complete reversal, almost like a healthcare distancing policy to keep sick or older patients out of the clinic where they might pick up coronavirus. And the last thing I would say is that, as stressful as this has been both for healthcare workers and for non-healthcare workers, I'm just amazed that every day my inbox fills up with people offering to help in any way possible. So I really feel like there's some larger lessons for humanity that have come out of this and hopefully will persist in the years to come. Thank you.
Thanks so much, Chris. Marietta, are you able to speak? Dr. Vasquez.
Yes. Can you hear me?
Yes.
Hi. So my name is Dr. Marietta Vasquez, and I'm a professor of pediatrics at the Yale School of Medicine, and my subspecialty is infectious diseases. And I'm also a Guilford resident. And the nice thing when your last name starts with a V is you don't have to say very much. Most of what I was going to say has already been said. But for the past 3 weeks, I've been taking care of children, both sick and healthy, in the outpatient clinics at Yale. And a couple of things that I want to stress. The first misconception is debunking this idea that children are somehow protected from this virus. That is simply not true. What is true is that children suffer lower rates of mortality compared to older individuals, but children do get infected. And currently we have children in the intensive care units of all ages nationally, and there are deaths in the pediatric population, although way lower than in adults. But what this tells us that it's important for persons of all ages to follow the preventive strategy. And because the severity of the pandemic has been the highest in adults, the diagnostic efforts have focused on adults. So we are not, as Karen and others have said, we are not currently testing as many children. The second thing is the protection of children should be exactly the same as that in the adults. And my area of expertise, as I mentioned, is infectious diseases and vaccines. And I want to stress that because we are in COVID-19 very focused, many other illnesses, such as vaccine preventable diseases, are not taking a break just because COVID-19 is here. And what this means is that all of you need to take your routine medications, you need to follow your regular treatments, and you need to get the vaccines that were recommended by your physician. And I understand that many of us have curtailed well visits for older individuals, but if your doctor said you need X or Y vaccine, please write it down, because the last thing that we need is, and it can happen, is an outbreak of measles or chickenpox. I mentioned that vaccines is my area of expertise. Rest assured that the first vaccine trials have started. Actually, exactly 10 days ago, the first dose of vaccine was given in one of the vaccine clinical trial units. Exactly how long this is going to take, we don't know. We've heard sort of figures that this can take up to 18 months. I'm hopeful that we'll have a vaccine within the year. And the last thing is that I think it's important to thank all those heroes in town who've done their part by staying home, by following guidelines, and also a thank you to all the people who've sort of been out of their way to send messages to those in the front lines, to people in stores, people in gas stations, people in supermarkets, because those are long days, and if you're all scared with what's happening, so are we in a sense. So thank you for the support.
Okay, thank you so much, Marietta, and to everybody. I want to echo those sentiments that we're very thankful to everyone in the community for their ability to step up during this crisis. So we're going to try to get into some of the questions. There's a few themes that have emerged. The one that I think is probably most prevalent as far as questions that I'm getting are about infectivity and preventing transmission. So I think maybe Dr. Parikh and Dr. Vasquez, as ID people, you could maybe address some of this. There's questions about whether we should be wearing masks in public. There's questions about whether when you buy groceries or get mail, you run the risk of getting the disease from that sort of a situation. Could you speak to those issues?
Sure. Either Marietta or I guess to lay kind of the groundwork, I think we still are considering that the incubation period for this disease is likely around 14 days at the outer maximum. But most people do present sooner than that, so most people are presenting around 5 days. So I think while the majority present within 5 days, there have been many cases of folks presenting out to 14 days, and that's really the incubation period. In terms of infectiousness, we're still following the CDC guidelines, so that if somebody has been found to have a positive test, but they're not having symptoms, they are considered infectious and should stay quarantined for 7 days following that positive test, and that's in the absence of symptoms. If you are symptomatic and you have a positive test, you are considered infectious and still need to quarantine yourself for at least 72 hours following the resolution of your symptoms, and that means resolution of fever in the absence of taking an antipyretic, fever-reducing medicine, and the resolution of improvement of your shortness of breath. In addition, also 7 days from the time of symptom onset. So those are CDC guidelines, and that's still largely what we're following. To get to the nitty-gritty, and I know this is what really affects people on a day-to-day basis, is how do I really protect myself then when I'm going out? And I think if, as we found on our private email discussions over the last 24 hours, probably all of us on this panel have a slightly different take on that. And that's because the data is just not completely all there for us. And that's particularly in regards to wearing masks. Now, my feeling on this is that it's most useful to be wearing masks. Certainly if you're symptomatic, you shouldn't be out and about. You should really be home quarantined. But folks, the use of masks is really meant mostly to, is more effective in preventing folks from spreading disease who are symptomatic. It is also effective in reducing one's risk in getting infected, but a little less so. And I think with the homemade masks, we just don't know how effective those are in both those instances. So my feeling is, if you are at all having any types of symptoms, you shouldn't be out and about. But if you are, I think a mask is not a bad idea. Or if you're a vulnerable population, so someone at high risk of disease, somebody who's immunocompromised, who has compromised lung function, has diabetes, maybe it's not a bad idea if you're out and about to reduce your risk of acquisition. But I don't think it's necessary, in my opinion, for everyone out and about to be wearing a mask all the time. Groceries, I think my wife, Brenda Emu, who's also an infectious disease adult physician at Yale, was at, I think, Fresh Market the other day, and they were limiting the number of people that can go in at the same time. I think what we need to be doing at our local grocery stores is kind of doing our best to limit, to enforce social distancing in the grocery store environment. So that's, making sure that you're not right behind the person in front of you in the checkout line, limiting the number of people going in. When you get home or get to your car, use hand sanitizer to wipe your hands. Preferably bag your own groceries if possible, but I know there's a lot of people who've touched groceries up until that point, so there are holes in that. But I think we don't need to be excessively neurotic on those things. We need to eat. So I think some of the common sense will go a long way. I'll stop there.
I have to agree with your comments. It's clear, the data, that if you're sick, you should be wearing a face mask. A few things regarding the homemade masks, because a lot of people are talking about this. Recently, there were lots of homemade masks, cloth masks, that were brought into the hospital as a donation. And I think as scientists, we want to stick with data. We should all know that rigorous studies comparing cloth masks to surgical masks. And surgical masks are the simple ones. They look like they're made out of paper, and they have, you know, the little ear elastics. Are lacking. So there are no rigorous studies that compare the effectiveness of these surgical masks to the homemade masks. So another thing to keep in mind is that these cotton masks, I think, in a way, may be harmful because of when you breathe into them, the condensation and the moisture can be trapped in there. And then when you take it out, if you don't dispose of them, wash them with chlorine or with, you know, good disinfectants and dry them in the highest setting possible, they could actually be putting patients at risks. The other thing to keep in mind is I see these mostly as a strategy to protect others from your cough. So I think it makes more sense for people who are actively coughing not to be spreading it, more than protecting the person wearing the homemade mask when they go out shopping. And the other thing is that personally, I think there's a big potential danger because I think it gives the people wearing a mask, irrespective of which type of mask it is, this false sense of security. That if you wear this mask, well, I can go to the supermarket every day because I'm protecting myself. So I worry that people are both going to have this sort of false sense of security and obviate strategies that we know are working. So I'm wearing a mask, so therefore I can get closer to you because I'm wearing a mask, especially if these are homemade ones. So I'm not saying that people shouldn't wear them. Obviously, there are extreme shortages, and I don't, every time I go out and I see people wearing N95 masks, all I can think about are, physicians and healthcare providers who are in the hospital and especially in other parts of the country where they're needed and they don't have them. But, if you have a surgical mask and you want to use it, go ahead. But, again, I think we need to be cognizant that there are really no data in terms of wearing regular cloth or making your own at home. And the other thing is that I think what this shows us is that medicine is not black and white, just like everything else in life. And we all have to get comfortable being uncomfortable. That, as you will see in this panel, these are sort of our opinions and our review of the very scant medical literature that we have, and that there's still a lot that we don't know. So in the end, people need to sort of listen to expert panels like the one we're putting together now, but in the end, you make the decision that makes sense for you and your family.
Thank you so much. And there was a related question about the availability of PPE. I can speak a little bit to the emergency department, and that at least we're being told we do have supplies, but it's anticipated they may run out in 2 to 3 weeks. Some of them are getting replenished. In the emergency department setting, most of my colleagues are given one N95 mask, which is the one that filters the smaller particles, and one surgical mask per shift, and they're looking at how to reuse those. So I do think it's important that people understand that, if they're buying up wherever the surgical mask, the N95 masks, and wearing those around town, that actually, may be limiting the supply for medical professionals. So I personally have no issue with somebody if they want to wear a homemade mask, if that makes them feel better. I agree with the comments about false sense of security, but just be aware that there are real shortages anticipated and real in the medical setting. So let's switch gears a little bit maybe and go to testing. Availability of testing for the virus itself, when you should get tested, how you can get tested. And also we've had some questions about the possibility of antibody testing. I've seen that come up as a possibility in Germany now, and people are asking about that. I'm not aware of any tests that we have available in the US, but I don't know if that's on the forefront. So if any of the panelists want to speak to testing on either of those issues, please do. And if you're muted, I need to unmute you.
Chris, the use of antibody from folks that they have recovered from viral illnesses such as previous outbreaks, it seems that it does work in a way of blocking the virus. But the thing is, we don't know whether the particular antibody that will be generated in the patients in the current settings of corona will have the same type of efficacy. So, but a lot of kind of activities going on of getting actually convalescent serum. Chinese did use, and apparently they were quite successful in reversing the pretty bad course of the illness by giving the blocking antibody to one of the COVID patients. So it seems that there are some countries actually going in that direction as well.
Just a few more things to add on the antibody side. I think there's two parts to this. There's one, the testing of it, and then as Vahid was saying, on the use of serum from people who have recovered in terms of a way to treat the disease. We still don't have antibody testing available really here. I'm sure it's going to come out, and it's going to be more useful, I think, in terms of understanding the transmission of the disease and how it's spreading, to get a sense of what percent of the population, what age groups are really exposed, since we're really not able to test nearly as much through the virus testing, so actually looking for the virus. The antibodies give us a sense of who's been exposed. I think it will be a really interesting thing once it's available, because it can start to let us know where we are in the epidemic, because there are kind of two ways that this epidemic is going to reach its end. I think it's either going to be when a large enough percent of the population is exposed and hopefully has immunity to it, or when we've done enough with our social distancing and other measures to really limit the spread. And by using an antibody, we might be able to distinguish which one of those things are leading to our decline in the pandemic, if that makes sense. So I think it's more of a tool that we're looking at to understand the disease, but not as much of a way to really identify individuals who are needing treatment, for instance, because it's a after the fact type of test.
Okay. Any other comments on that from the panel?
Yeah, this is Chris Rooster. So I would just say, so one of the things at a more basic level, when you're thinking about testing and why testing isn't as widely available as it might be, is that actually what we've seen, so there's different ways the tests are run. So in most cases, you're at a drive-up testing or at a healthcare provider's office, right? You're getting a swab that's put inside your nose, usually a nasopharyngeal, so it's put in pretty far inside your nose. And then that swab is taken to a lab. And at the lab, right, there's different manufacturers and different ways that it can be tested. There was the initial way that the CDC had wanted it to be tested. And one of the big problems with that was distribution of the actual apparatus and chemicals to run that test. And actually, the way that that test was run was sort of problematic. And so state departments of public health, when this initially started, the idea is it wouldn't be so widespread. And so state departments of public health would be able to keep up with it. And at one point, there were like 100 tests in the entire state of Connecticut. And that was probably only like 4 or 6 weeks ago. And then what you've seen happening, which I think is some good news, is that you've seen more and more companies kind of come online with different ways that virology labs can actually take your swab and run your test. But even in that environment, places like Yale and VA Connecticut, we have the capability to develop in-house assays and run tests in an hour. But what happens is all of a sudden the reagents that are used to run those tests get used up around the country, and you develop a shortage. The good news in this last week is a couple other big companies, Roche, which worked with Quest, and has a stable supply of the ability to actually do the test, is up and running. And so if you do a drive-up test around the state, usually it's typically sent to Quest. And then another company came online that uses the same kind of mechanism that we use to test for the flu, which can turn around in 45 minutes. Again, it's limited supply right now. And so those kinds of rapid tests are being prioritized for very sick patients in emergency rooms or in inpatient. But I do see promise that they'll become more widely available. And then you have other even more rapid tests and even home testing kits that you would mail in that are on the horizon. But the one thing that's still the Achilles heel of all of this, believe it or not, is the availability of the actual swabs and viral medium and the collection kits. That's getting better as well. I do see some hope on the horizon that as these kind of like the supply chain of how you test and the reagents and the chemicals and the mechanisms, I really do see a windfall happening in the next couple of weeks. The testing will be a lot more easy.
Okay, great. We had a question, and I think this speaks to the importance of social distancing as well. Why are we continuing to see this increase in cases, and how bad is it? I believe there's only been a handful of cases that are positively identified in the actual town of Guilford. There's clearly a lot more that are presumed to be positive but may not have been tested. But I do want to comment, just from watching the statistics at Yale, that the numbers do continue to rise at a fairly, they're going up quickly still. We received data today that there were well over 100 admitted patients and several dozen on the ventilator. It's not reached the capacity at Yale, but it continues to increase. So I want to sort of balance the importance of this with, not creating panic that we're out of capacity. But could someone speak to the reason why these cases continue to rise, even though we're doing social distancing, and what we need to do about this going forward?
I take that. I think.
Marietta,
Oh, go ahead.
Go ahead.
Yeah.
No, I think it still has a lot to do with testing. We're in sort of the infancy stages of testing, and more, as more tests become available and they become the turnaround is quicker, and physicians are starting to know how to order this test. Just to give you an idea, on March the 10th, we sent a patient for outpatient testing. And the process is we put in an order. The patient, if they're stable, obviously gets masked and goes home. And then the patient gets called and gets an appointment to come for testing to a specific site outside of the hospital. And that patient received an appointment on March the 29th, so 9 days later. And the results take 5 to 7 days. I think if you think of that system that takes almost 2 weeks for the patient to get tested and for the results to come back, then that's kind of a disincentive for testing. As the test becomes more readily available, then we're testing more. I forgot to mention one piece of good news as you were talking about testing, is that the other thing that's difficult is these swabs have to be introduced all the way to the back of the nose until you sort of hit the back of your nasopharynx, and it invariably makes patients sneeze, cough, and they were one of the instances where spread was very common to the people obtaining the test. Now there are new data which I think bring up a very good piece of news, that you actually don't need, with some of these tests, you don't need to go all the way down, so you can easily introduce it to the tip of the nose. So I think overall we're still getting to the point where if everybody can have a test, then we've sort of reached the point where we can say, all right, are we truly seeing more cases or fewer cases? But that's my opinion. I think we're just testing people who we weren't testing before.
I have some things to say about this too. I think that we have a 6-year-old at home who has a runny nose and no one thinks anything about it. And the mom is a nurse and she goes to work and she sees 5 people that day. And that's how things spread. And we are about 2 weeks away from that exposure. So everything that we're doing now to help is going to help in 2 weeks. But what we weren't doing 2 weeks ago, we're now seeing at this point. So I think that testing is really the key, and we're not there yet. If we could test all those kids with cough and a runny nose that, you know, no one is thinking much of, then we can make a lot of progress on stopping the spread.
Karen, while you're on, could you speak as a parent and pediatrician to the importance of social distancing with the pediatric set and any strategies to help with that?
Yeah, I have 3 teenagers who are not very happy with me right now. They're staying at home. They are bored. They're not seeing any of their college friends. They're not seeing any of their high school friends. They're not going to play basketball next door with the kids playing basketball. They are staying put. And, you know, there are better moments and worse moments. Sometimes they're more understanding. But I think the bottom line that, you know, as parents, we have to impart that this is our social responsibility to do this. You know, this is not because we're protecting our kids, although we are, but we're really protecting our community. And, you know, this is a mandate that all of us have as citizens, you know, in the world right now. So that's how I put it to my kids. They know that there is no discussion. They're not going anywhere. They're not picking up milk on the way home from anywhere. They're not going to the, you know, drop off a package for mail. They're not doing anything. They are staying home. They're going outside. They're going for walks with our unit. And that's it. And, you know, that's what I've explained to my families that they have to do. And I think that's what all of us have to do with our families and with our friends. And yeah, it's not easy. It's not easy for any of us.
Not so bad for us.
Okay. I've seen some questions about the symptoms. I saw one, runny nose is not one of the symptoms, correct? I think that's probably true. I think one of the things to emphasize here is that, first of all, there can be asymptomatic carriers and spread of this virus. It also can coexist with other viruses. So, you know, you could have a run-of-the-mill common cold along with coronavirus. That has been reported both with influenza and other viruses. There have been some questions also about symptoms. You know, do these patients present with GI symptoms alone, like gastrointestinal symptoms, abdominal pain, diarrhea? Is loss of smell or taste a sign of this disease? Does anyone want to comment on presenting symptoms and how that might affect things?
Chris, I might chime in on the runny nose. So there definitely is, there are a small number of patients who present. I think from more recent studies on a 5% range of folks may actually start with a bit of a runny nose, a sore throat. Some of the things we didn't think were as common. And they certainly are not as common by any, but we have been seeing some folks present with that. There also have been a handful of cases at Yale of folks presenting purely with GI symptoms, so gastrointestinal, nausea, vomiting, diarrhea, those things. It's not unusual. We see this, you know, influenza virus often in kids presents a little differently than it does in adults. So I think as it gets through more of the population, will be more unusual report. So I think runny nose excludes it. I think that's the main message I want to across. But you don't have to worry that every runny nose is this. I think one of the big challenges that folks in the healthcare setting in Guilford here, pediatricians and the internists are going to be running into issues as we get into the allergy season, and I think that's going to be an additional challenging period because we're so, you know, runny nose, sore throat can be seen with it, less common, GI as well, but less common, but they don't exclude it.
Thank you. So feel free to type in questions. I'm trying to catch up with some that are on there, but if there's important ones that you want to emphasize, please feel free to type those in. We did have one question, which I'll throw out to the panelists in general. Are there any myths about coronavirus that you see that are out there that should be addressed from your perspective?
I think the myth that kids can't get really sick from it, or that if you're healthy, you can't really get sick from it. I mean, there are lots of stories of healthy 40-year-olds that are dying from this, or that are on a ventilator from this. So, you know, it's scary for all of us, because I think that we are, you know, all susceptible to this.
Yeah, I would echo that. I just, you know, I'm on a lot of groups, honestly, via Facebook, that talk about, you know, healthcare workers that are facing this and coming down positive, and the challenges they face going home to their families after caring for patients are not insignificant. So again, we appreciate everyone's efforts to try to limit this spread. Anyone else want to comment on any myths or misconceptions?
I would just, Chris, this is Chris. I would just add, can you hear me, Chris?
Yes.
Yeah, I would just add, I think that, you know, not to be less than hopeful, but I think there's probably a little bit too much stock put into some of the early results of treatment. And so the whole, you know, chloroquine, hydroxychloroquine, and getting excited that a combination of antibiotics and that medication might work was not based on a whole lot of science. And so while I don't want to, you know, take away hope that some medications might hold promise, I also think that the ability to treat this with medications that we know of, including even some more high-tech medications like IL-6 inhibitors and other antivirals, is probably a little bit overstated at this point in the evolution of the disease.
Yeah, we've actually seen some reports of toxicity from people trying to medicate themselves, so we do not recommend that. All right.
I wouldn't mind. Chris,
Oh, go ahead. Go ahead.
I echo what Chris just said about the drug therapies. I mean, I think there's been inappropriate prescribing in a lot of psychiatry for some of these, and several of them are already in shortages around the country. For instance, Plaquenil or hydroxychloroquine is actually a really important drug for folks with certain diseases like lupus and rheumatoid arthritis, and there are real shortages of those drugs being available for those folks. So I think azithromycin, that initial study was from 6 patients, a combination, and it looks promising, but that's far from the amount of data we need to really recommend that. So I think there's real dangers in stockpiling and prescribing these things. Not to say that they might turn out to be effective, but I think all of these drugs have to be administered and given under the care of a physician and under guidelines that are based on more data.
Thanks. And along those lines, these panels are great. And there are many things that Dr. Google does well, and Dr. Facebook and Dr. Instagram, but please stick to medical websites. There are plenty of educational venues out there, like the ones we're doing for Guilford. Most of them are open. There's a big difference between a website that is .com and .gov or .edu. So I would just urge people not to believe absolutely everything that they see a friend post on, you know, on Instagram or on Facebook or on the website, because that's dangerous, and it can leave patients who truly need their medications without them, because then everybody runs and asks their neighbors to prescribe unnecessary and dangerous drugs to them, and likewise for many other pieces of information.
Great. So I'm getting close to the hour. I do see a question that I think is important. was just put out. What is the directive for patients who are at home, I assume have been symptomatic at some point and possibly presumed to be COVID-19, quarantined for a couple of weeks, but are now asymptomatic and seemingly over the virus? When is it okay if these people are not having active symptoms to go back at all, into the community, and what are our guidelines on when do people stop shedding and that sort of thing?
So when you're exposed, you have to quarantine for 14 days and a few more days of negative symptoms. If you don't become symptomatic, it means you were not infected, or at least didn't have a clinical infection. I don't think anybody should take that as a great, now I can go outside, because really the guidance is that we should all be staying home. Quarantine within the house is very difficult to do, and the CDC website has guidelines on that. The person who's infected and others, they should be in separate rooms if you can, in separate bathrooms. I always, think I take care of the needy in New Haven, and I think that many of these guidelines were written by middle class America. If you're an undocumented immigrant, if you're a refugee, if you're a family of 10 and you live all in one room and you share one bathroom, it's going to be impossible to do that. So we keep that in mind. In terms of shedding, we know that individuals shed. They can shed in their respiratory tract, and they can shed in their GI tract as well. There's a study from China that came out, I believe, in Clinical Infectious Diseases, to show that infants can shed the virus up to a month. So I think, just because 14 days later you didn't develop symptoms, it doesn't mean that you're completely out of the woods. I think, we all need to do strict hand washing before and after, every time you go to the bathroom, every time you handle anything. I think the bar is still very high for us to be vigilant and be observing all of these hygienic techniques.
Chris?
Yes.
Yes, I think there are a lot of questions about handling material coming at their doors for shopping at the groceries, how long to keep them away, how to treat them before they start consuming it. Someone can maybe comment on that. I think there are a lot of questions coming in that type of direction.
I can comment, even though I'm not an infectious disease person. If you guys want to add something, I can take a stab at it. But there's actually a really great resource by a food microbiologist that I referred to, which goes in opposition to something done by a medical doctor wearing scrubs, a video that was super scary of things that you should do to your groceries in order to consume them safely. That horrified me. Uh-oh, my connection's unstable. I don't know if you can hear me.
Yes,
so
I can.
The more rational thing is to take things out and wash your hands. And just because studies have shown that virus microparticles can exist does not mean that that is infectious to you. So washing fruits and vegetables with water, and washing your hands and putting stuff, bringing in your mail and then washing your hands. It's very unlikely, unless your mailman sneezed into your mail and you took it right out of his hand, that is going to be what's going to get you infected. So I feel like those are the things that terrify us, but really it's our human to human interaction. It's our kids playing with other people's kids. It's us standing too close to someone else. It's someone going to the store when they're coughing. Those are the things that are more problematic than the inanimate objects.
That's very helpful. Thank you. There was a question about why or what the mechanism might be for an antibiotic like azithromycin. I've actually had a few questions about this from community members about, well, why didn't we put them on antibiotics earlier? My understanding of this is that a lot of patients who are symptomatic will have essentially what look like infiltrates on their chest radiograph, which can be difficult to tell if that's bacterial or viral. I think in most cases in this disease, it is actually a viral issue. However, we're covering with antibiotics. So, I'm not expecting the antibiotics such as azithromycin to be a magical cure in this case. And I don't know if the ID docs or anyone else wants to comment on that.
Chris, azithromycin or Zithromax is not recommended at this point. So we stopped using it. That was based on a very, very small study out of France on 6 patients that they showed that azithromycin and chloroquine was quite effective, but there's a recommendation not to use that because side effects and being ineffective. So that's out. And the only thing currently we are using in the ICU is hydroxychloroquine. And the antiviral, it's basically under research protocol.
Okay.
They only, both hydroxychloroquine, chloroquine, and azithro also have some anti-inflammatory properties, so maybe that was related to some of the potential benefit. But again, it's clear, and as Fahim said, it's not recommended at this point. Just to give you an idea, both of those drugs can lead to arrhythmias or abnormal heart rhythms in folks. If they're combined together, it's even a higher risk. So there's a real risk of starting to use these medications without a lot of good trial data.
And for people that are symptomatic, I've seen this question a couple of times. There were some reports about ibuprofen being more problematic than Tylenol. The most recent stuff that I've seen on this did not really bear that out. But I don't know if people could comment on that, any of the other doctors.
Unfortunately, I think like a lot of these things, we're getting information in kind of bits and drabs. And I agree, Chris. What I've seen recently shows that the anecdotal information has not really borne out. However, we are telling people to start with Tylenol. If you can't find Tylenol because there's been a run on it in the CVS, we are telling people who have kids with high fevers to go ahead and use ibuprofen.
That's very helpful. Thank you.
Chris, may I ask our infectious group, this question is that fever is good, works against the viruses. So if the kid or the adult is not having a major febrile illness, maybe we shouldn't actually start lowering the temperature, because the biology of the virus actually nicely done. If you raise the temperature to 38, just 1 or 2 degrees Celsius, survival actually drops down quite a bit, the virus. So that's my question about our pediatricians and infectious disease friends, to see whether we should all treat everyone with fever.
I guess that's me. The fever is not an illness, and we always teach this to the medical students. Fever is a response not only to an infection, but to many things. Having said that, allowing a patient to be febrile and not treating it in the face of a upper and lower respiratory infection that can be as severe as this is, I think is playing Russian roulette. When you have a fever, your respiratory rate goes up, your metabolic demands increase. And personally, I would not, and I don't do it in patients with influenza, allow them to be febrile and sort of sweat the fever on their own. When it comes to children are at higher risk, especially the young ones, for febrile seizures. And it's not how high the temperature is, it's how quickly that temperature rises. It's the difference from having a normal temperature to having a high temperature. That's what makes people have seizures, or the opposite. Having a high temperature and, for example, being dunked into a bath with ice, that can cause febrile seizures. So not for my patients.
Doctor, what the other guy was saying was,
Right.
it doesn't survive as well at high temperatures.
Right.
So why don't we just let the people with the fever stay with the fever? And what she was
I'm
saying.
sorry, who's talking right now? You're coming across quietly. We're getting close to, we're actually over our time, and I want to be respectful of people's time. I really do appreciate everyone who's participated and come out. I know we probably didn't get to everyone's questions. I do apologize for that. We just have some limited time. It's possible we could redo this at some point if there was a lot of interest. I certainly learn from other professionals in doing this. Again, want to thank all of the panelists, Barry Felsen for this idea and for helping to moderate the questions, Matt Hoey and the other leadership in town, Dennis Johnson, Christine Cohen for your leadership. And if anybody else has any other remarks before we sign off. I'm trying to record, I have been recording this, so I will try to convert it to something that we could post, probably at YouTube, maybe the easiest, and then have it accessible via various venues throughout the town. So thank you again to everyone. And again, really appreciate the efforts of the community in all of the things you're doing. Social distancing, it makes a huge difference. I do think it's going to be a few more weeks before we know where this is going. Longer term, at least a few more weeks. So thank you for your patience. And I guess that's it. Happy Doctor's Day.
You too, everyone.
Happy Doctor's Day.
All right. Take care, guys.
Bye.